Hi, this is Jeff Klein, editor of RadioGraphics, and today I am pleased to have with us Dr. Prabhakar Rajiah and Praveen Ranganath from the Department of Radiology at Mayo Clinic in Rochester, Minnesota, and the Massachusetts General Hospital in Boston, Massachusetts, authors of one of our featured papers in the current October 2020 monograph issue of RadioGraphics. Their article is entitled Utility of CT in the Evaluation of Transcutaneous Mitral Valve Replacement. Doctors, welcome to our podcast. Prabhakar, let's begin with you. Many of us that have been imaging patients for transcatheter aortic valve replacement in the last 5 or so years are intrigued by the development of transcatheter replacement for diseased mitral valves. Can you summarize the large recruitment trials that are currently underway and how many centers in the United States and worldwide are performing this procedure? And we can gain some perspective on the subject of your article.
Sure. First off, thank you, Dr. Klein, for having us on this episode of the podcast. The field of structural cardiac imaging has rapidly expanded over the last decade, mainly because of TAVR, and as you have mentioned, with new transcatheter interventions, including mitral valve replacement procedure. So compared to TAVR, TMVR is still in its nascency. To put this in perspective, a recent 2019 meta-analysis from Lascani and colleagues for TAVR in intermediate risk patients included over 5,000 patients. By comparison, a meta-analysis that was performed around the same period for TMVR included only 308 patients. So far we have results from proof of concept trials for some of the most popular TMVR devices, and these have been promising, and these have prompted larger trials which are currently ongoing. So currently there seems to be 9 registered clinical trials recruiting patients from about 139 centers around the world, and there are an additional 9 active trials which are still not recruiting. So while TMVR is new, this is causing a lot of excitement among the TMVR, the structural heart disease community over the world. So at present, we do not have any specific CMS data for TMVR in the US because none of the devices have been FDA approved yet. And in Europe, the Tendyne device just got its approval in January of this year. So we don't have any specific numbers yet, but we are hoping to get it soon.
Terrific, thank you so much. Praveen, let's move to you. You briefly discussed in the paper the use of the MitraClip for transcatheter mitral valve repair. And after a review of mitral valve anatomy, you detail the TMVR devices that are currently being evaluated, none of which I should point out are, as of yet, FDA approved. Figure 2 shows illustrations of several of these devices. In Figure 3, the 2 main approaches to TMVR implantation. Can you review those devices and the approaches that are used for placement? In particular, which devices require which particular approach?
Yeah, of course, Dr. Klein. So in general, there are 2 types of transcatheter mitral interventions. There is a transcatheter valve repair and a transcatheter valve replacement. The MitraClip device that you mentioned is a specific transcatheter valve repair option, which uses a leaflet edge-to-edge repair technique. In our review, we focus on the transcatheter valve replacement devices. There are over 30 known TMVR devices and even more in development right now. It's important to note that in our paper, we discuss only the most popular TMVR devices for which we have published proof of concept data. With one exception, all of the TMVR devices that we mention are specifically designed for the mitral position. Before we review the devices, let's take a minute to talk about implantation approaches. In general, TMVR devices are implanted via one of 2 techniques. There is a transapical approach and a transseptal approach. The transapical approach is by far and away the most common approach for dedicated TMVR devices. When I say transapical, I refer to implantation via a left ventricular apical access through the chest wall. So transapical access gets a pretty straight shot from the apex across the LV through the mitral annulus. This is important because compared to TAVR, TMVR devices generally have a larger device profile. So transapical access allows for placement of these larger caliber rigid trocars needed for implanting these larger profile devices. Now, in contrast, transseptal approaches refer to device delivery via puncture of the interatrial septum. Rather than directly accessing the left ventricular apex, we access a large systemic vein, often the femoral vein, and then the device is delivered up the vein into the right atrium, then across the septum into the left atrium, finally antegrade across the mitral annulus. Now let's talk about those devices that you were mentioning. The dedicated TMVR devices we mentioned in figure 2 of our paper are the Abbott Tendyne, the Neovasc Tiara, the Medtronic Intrepid, the Livanova Kaisan, and the Cardiac Edwards devices. All of these dedicated TMVR devices require a transapical approach for implantation. Many of our listeners have probably heard of or even used the Tendyne device, which has anecdotally been increasing in popularity in the States. And we already talked about the CE marking that it received in Europe. I'll also note here that the Cardiac Edwards device is no longer being manufactured. Finally, let's talk about the very popular Edwards Sapien 3 device. The Sapien 3, it's a balloon expandable stented valve that was designed for TAVR. Many interventionists are very familiar with the Sapien 3 system because of TAVR and are now translating its use to the mitral position. So for TMVR, the Sapien 3 is placed almost exclusively via a transseptal approach. There have been some transapical and even open surgical approaches that have been described, but those are far less common.
Great, thank you so much. Prabhakar, let's move back to you. So moving on to the imaging, echocardiography is obviously widely utilized for detecting mitral valve disease, and CT is the essential imaging modality in pre-procedural planning for these procedures. You point out in the text and in Table 4 that these imaging studies play complementary roles in the evaluation for TMVR. Table 6 provides a protocol for retrospectively gated triphasic contrast CT examination, which you point out complements echocardiography in evaluating mitral valve pathology and allows for dynamic evaluation of leaflet motion. Can we look at movie 3, which shows an example of mitral stenosis as depicted by Cine-CT?
Sure. Dr. Klein, as you mentioned, echocardiography and CT are complementary in pre-procedure planning. To understand why they are complementary, it is important to review the strengths and weaknesses of these modalities in the context of TMVR. Echo is the primary modality that is used in characterizing mitral valve disease because it is widely available, has a great temporal resolution, good spatial resolution, and also allows for quantification of hemodynamic metrics like pressure gradients and also regurgitant volumes. However, echo has limitations. Particularly, it is operator dependent. It requires a significant amounts of time for image acquisition, and it is also limited by acoustic windows, so it cannot really evaluate structures which are adjacent to the heart. In addition, currently, echo cannot simulate a virtual prosthesis or a NeoLvot. So these weaknesses of echo are where CT excels. CT, especially multi-detector CTs in which these studies should be performed, can now be performed rapidly as fast as 3 seconds, and these are getting more widely available with time. CT is not limited by acoustic windows, so it can provide valuable information about important surrounding structures that can be injured during the procedure. CT also obtains isotropic volumetric data, which allows reconstruction in any plane. And as movie 3 shows, this is an case which was acquired with retrospective ECG gating. So in the 4-chamber view, we can see that the mitral leaflets are thickened, specifically the anterior leaflet, which also has calcification. And there is also severe enlargement of the left atrium. So all these are features of rheumatic mitral valve disease, which is shown well using CT. What CT cannot do is that to provide hemodynamic information, which echo provides, but CT has a tremendous value in evaluation before the procedure because most of the current post-processing software packages, they have specific programs for TMVR, which can simulate virtual prosthesis, and also the NeoLvot, which are very critical parts of TMVR planning.
Great, thank you so much. Praveen, let's move back to you. In the paper next, you review the critical pre-procedural CT parameters that are to be evaluated, beginning with mitral annulus, which has a very complex shape, obviously. Unfortunately, it can be delineated using commercially available software. Can you take us through this as we view movie 5?
Sure, Dr. Klein. As you know, delineating the annulus is a very nitty-gritty process. So I'll talk about movie 5, focusing on some of those details. In movie 5, we are demonstrating how to identify and measure the 2D D-shaped annulus using CT on the Circle 42 software. So note that there's other software programs and similar dedicated TMVR packages within these programs. We just happen to be using Circle 42 here. First, you're going to want to select the phase of the cardiac cycle in which the mitral annulus is largest. Typically, that's at end diastole, or about 70 to 80% of the RR interval. Another way to find it, the optimal phase that is to watch for closure of the mitral valve on the Cine images. Once that phase is selected, we go to the axial CT images and then assign the approximate center of the mitral valve. That often triggers the automatic algorithm within the software packages. Most software programs will then automatically generate a short and long axis view of the mitral annulus plane and draws a line from the center of the mitral annulus through to the left ventricular apex. In other programs, you may have to manually assign the left ventricular apex. We separately discuss how to manually do this process, but movie 5 shows the automatic process here. Next, we have to create the saddle-shaped 3D mitral annulus perimeter. So we use the long axis images of the mitral annulus plane and rotate around the annulus central axis, beginning to place seed points at the insertion of the mitral valve with the myocardium. Posteriorly, those seed points are placed at the insertion of the posterior leaflet with the myocardium. Anteriorly, it's a little trickier. This is where we have the so-called saddle of the anterior horn of the saddle. Anteriorly, we place these seed points at the junction of the coronary cusps with the intervalvular fibrosa. In this software, we use 16 different seed points that are evenly placed in a stepwise fashion around the annulus until we cover an entire 360 degrees. From the seed points, we then create a cubic spline interpolation, ends up being a line around the seed points. This represents the 3D perimeter for the saddle-shaped annulus. So right now we're at the 3D saddle shape, but remember we need to get to the 2D D-shaped annulus. So to get from the saddle-shaped annulus to the D-shaped annulus, we have to cut off that anterior horn. For this, we have to identify the medial and lateral trigones. The trigones on CT appear as hypoattenuating triangular structures that are best seen on the short axis plane just when the LVOT disappears. So once we identify those, we exclude the anterior horn of the saddle-shaped annulus by drawing a line between the medial and lateral trigones. So this will form the 3D D-shaped annulus. From here, we project the 3D D-shaped annulus onto the short axis view, and we form the 2D D-shaped annulus perimeter. It's from this 2D D-shaped annulus perimeter that we create and measure all of the important annulus measurements.
Thank you. Very, very detailed evaluation, obviously. Prabhakar, a significant part of the article reviews the anatomy of the left ventricular outflow tract, or LVOT, and in particular the NeoLvot, which will be created following TMVR. Can you take us through the process of estimating the anticipated NeoLvot and why this is so particularly important?
So the evaluation of NeoLvot is one of the most important, if not the most important part of pre-procedure planning with CT. To start with, the LVOT is the channel through which blood exits the left ventricle during systole. This is bounded anteriorly by the basal anteroseptum and posteriorly by the aortomitral curtain. So when the TMVR device is placed in the mitral annulus, the anterior mitral leaflet is deflected further anteriorly, and this narrows the LVOT. So the name coined for this narrowed volume is the NeoLvot. It is critical to evaluate the NeoLvot before TMVR in order to prevent outflow obstruction, which is one of the most dreaded complications of this procedure. So the narrower the NeoLVOT, the higher the risk of LVOT obstruction. Outflow obstruction in the acute setting can be lethal and should be avoided at all costs. Anyway, let's talk about how to simulate and measure the NeoLVOT. Again, similar to annulus measurements, most of the currently available software have algorithms which can do this measurement. So what we want to do is to simulate the narrowest possible NeoLVOT size. So we begin with a 3-chamber view at the end systole, which gives us a long axis view of the LVOT. Then using the post-processing software we discussed before, we simulate a virtual valve in the mitral position. This virtual valve is essentially a 3D rendering that mimics a real TMVR device. So typically this valve is positioned with an 80% ventricular and 20% atrial offset. So with the virtual valve in place with this offset, we now see that the NeoLVOT in a long axis. Then what we do is draw a center line along this long axis of NeoLVOT and obtain corresponding short axis views which are orthogonal to the center line. So along this center line, we find the point in the NeoLVOT where the short axis area is going to be the smallest. And this is the key measurement to obtain and report the minimum NeoLVOT area. As we discuss in this paper, there is no universally established cutoff for a small NeoLVOT area. Proposed cutoffs range from 130 to 200 square millimeters. We usually use 200 square millimeter as our cutoff for a small NeoLVOT area. There is also some debate over whether we are overestimating the risk of NeoLVOT obstruction by measuring this at end systole, and some are proposing measurement at a different phase. However, there is no consensus on this as yet. So I encourage the readers to take a look at our paper at the section on advanced techniques for dealing with a small NeoLVOT, because a small NeoLVOT doesn't mean that we cannot do this procedure. It still can be done after doing some additional procedures like a septal ablation or a lampoon procedure. CT plays an important role in planning these procedures too.
Great, thank you so much. Praveen, the next anatomic consideration is the CT estimation of the fluoroscopic angle, perpendicular to the mitral annulus, or the coplanar angle, which is needed by the interventionalist for proper deployment of the device. Figure 14 illustrates how this simulation is performed pre-procedure. Can you take us through this?
Sure, Dr. Klein. TMVR is performed similar to TAVR using fluoroscopic guidance and almost always has transesophageal echocardiographic guidance as well. We know from extensive work in TAVR already that CT can accurately predict the optimal fluoro angles needed for device deployment. So similarly, CT does a pretty great job of determining the optimal TMVR angles as well for fluoroscopy. This is particularly important for TMVR in native valves because there aren't very good identifiable landmarks on fluoroscopy in native valves. For valve-in-valve or ring or even valve-in-MAC, there are some pretty reasonable identifiable fluoro landmarks, so the pre-procedure fluoro angles aren't as important but can still be provided. Anyway, most CT post-processing programs do have a method of representing a volumetric image of the left heart lumen that's used to simulate fluoroscopic angles. Creating views that are tangential or orthogonal to the annulus plane are most helpful. The key tangential views are the so-called SL or septolateral view and the compromise view, and the key orthogonal view is the en-face view. The SL view has a line of sight parallel to the septolateral distance measurement of the mitral annulus. This view gives a nice long axis view tangential to the annulus that's optimal for device positioning. We use the septolateral distance rather than the trigone distance because a TT view is often technically not feasible with a C-arm because of where the operator is or access limitations. Next, the compromise view is somewhere between the SL view that we discussed and the unfeasible TT view. The compromise view is also tangential to the annulus, but it really helps profile any potential NeoLvot narrowing that may be present. Lastly, the on-FOSS view has a line of sight down the annulus central axis, so it's orthogonal to the annulus plane. This view helps ensure that the delivery sheath is well centered within the annulus. It's also really helpful for valve in ring and valve in MAC procedures. I'll note here that there is no established consensus as yet on which specific views are important for TMVR. For this reason, it's often helpful to provide the continuous coplanar curve of fluoroscopic projections that we're showing in our figure in order to remain tangential to the annulus. This way, the operator can select the easiest achievable projection angles based on their preference.
Great, thank you so much, Praveen. Prabhakar, let's conclude with this. Following a discussion of the landing zone characterization, specifically mitral annular calcification and relationships to adjacent structures such as a left circumflex coronary artery and the coronary sinus, you discuss and compare the transeptal versus the transapical approaches. You also provide a CT report template that our readers will find useful as they perform and interpret these examinations, and also the use of 3D printing for pre-procedural TMVR planning. Let's finish with the use of CT in post-procedural imaging. We'll show movie 18, which demonstrates the most concerning complication related to TMVR.
Dr. Klein, as you mentioned, movie 18 shows the most dreaded complication of TMVR, that is LVOT obstruction. This is defined as a post-procedural elevation of LVOT gradient by at least 10 millimeter mercuries. Now, TMVR-induced LVOT obstruction is usually diagnosed during the procedure itself and also typically managed during the procedure. However, sometimes this may be shown in a post-procedural CT, as in this case in movie 18. So here, the cine-CT demonstrates a severe narrowing of LVOT by the TMVR device, which is protruding extensively into the LVOT. As we discuss in this manuscript, LVOT obstruction is more common for valve in mitral annular calcification than with a native valve procedure. The risk of NeoLvot obstruction is higher with higher device flaring, protrusion, and skirt size. In addition, higher iotomitral angle, increased basal septal thickness, and longer anterior mitral leaflet are patient-specific factors that also increase the risk of NeoLvot obstruction. As we have discussed earlier, pre-procedural CT plays a very important role in predicting the risk of NeoLvot obstruction.
Well, Drs. Rajiah and Ranganath, I want to thank the both of you for taking the time today to discuss your paper on the utility of CT in the evaluation of transcutaneous mitral valve replacement, which readers can find in the current 2020 October monograph issue of RadioGraphics. Doctors, thank you very much for your time, and thanks for a wonderful paper.
Thank you, Dr. Klein.
Thank you.